So let me introduce Raphael and Neil. Dr. Raphael Lee is the Paul S. and Eileen T. Russell Distinguished Service Professor at the University of Chicago and is with the founder of the Chicago Electrical Trauma Rehabilitation Institute. He is a PhD electrical engineer and a plastic surgeon. His journey took him through MIT and Harvard before he landed at University of Chicago. His research is focused on the biophysical pathogenesis and treatment of trauma, including electric shock injuries. He is a life fellow of the IEEE and has been elected to the National Academy of Engineering, the American Surgical Association, and the International Academy of Medical and Biological Engineering. He's received many awards and honors. He's recognized around the world as the center of knowledge in electrical trauma. Dr. Neil Pliskin is a PhD neuropsychologist. He's the professor of clinical psychiatry and neurology at the University of Chicago, or University of Illinois at Chicago, and is one of the collaborators, along with Dr. Lee, in the Chicago Electrical Trauma Rehabilitation Institute. He's a board-certified clinical neuropsychologist and past president of the Society for Clinical Neuropsychology. He has devoted his clinical career to investigating cognitive and behavioral disorders, including brain trauma and electrical injury. He is the fellow of the American Psychological Association and the National Academy of Neuropsychology. He was awarded a presidential citation by the American Psychological Association in 2010 for dedicated service to the profession as an advocate, scientist, educator, and practitioner of neuropsychology. Indeed, my pleasure to introduce, I think Dr. Raphael Lee is our first speaker. Let's welcome Dr. Lee and Dr. Pliskin.
Thank you. So thank you, Lanny. That's really fantastic, really honorable recognition. To say that I'm the center of knowledge is a little bit over the top, but we've been working. I've had the pleasure of working with a wonderful team, and for the last 30 years, slightly over that, on the problem of electrical injuries. We want to share with you some of the information that we have learned. There's still more questions than there are answers. Let's see if I can get a hold of this. And we're going to do a bit of a hybrid presentation. Dr. Pliskin is going to be wired in through Zoom, and hopefully we've gotten things ironed out and coordinated so that this gets done in a timely fashion. But so first of all, thanks to you guys. I participated in this meeting for a number of years, approximately 20 years ago more, and this society has really grown. And if you look at the problem of electrical injury, it's the safety people like yourselves that have made a huge difference in terms of number of people being injured or the consequences if you're just measuring numbers, despite the fact that exposure and use of electricity and electrical power is increasing all the time. So, the tribute belongs to you. And it's gratifying to me to see the growth of this organization. So I just feel great about the future being here. So, okay, but it's still a problem, right? That's why we're here. And there are still many, lots of electrical injuries go unreported. What numbers you see in the American Burn Association of, several thousand cases receive, hospital attention. Is probably much less than it really is. But on the medical side, the treatment of electrical injury hasn't really changed a whole lot over the last few decades. And there's a reason for that. Part of the problem is that it is a really complicated biophysical problem, the electrical shock injury, because electricity can do damage to tissues in more than one way. It's widely recognized that passing current through a conductor is going to generate heat, and you can see sometimes patients with long contacts get significant thermal burns. But also, there's a lot of electrical things in the body, including the cell membranes and the proteins and so forth, that are acted upon by the electrical force that's generated by the contact. And of course, that force and the damage that occurs from that happens in milliseconds, and it takes typically on the order of seconds to cause significant thermal damage beyond the point of skin contact. So it was the recognition of the non-thermal aspect of it that really sort of was a game changer. One of the things that we were involved in the 1980s, and that led to realizing that or giving insight into the complexity of the clinical manifestations. Now, so in addition to that, when the current passes through the body, the current density is not uniform, right? Because the cross-sectional area is not the same from one location to the other. Like in this illustration here, the current passing from hand to hand, as the current passes through the chest, the ability, it has a much wider current path, and the current density is much lower. And by Ohm's law, we know that the current density and the conductivity of the tissue are the determining factors for the electrical field strength, which is the main thing that matters in terms of kinetics of damage. So, okay, so it's a very non-uniform injury pattern. Okay, that adds to the complexity of the problem. So, and in addition to that, not all tissues are equally the same in terms of their susceptibility to injury. Skeletal muscle and nerve tissues, skeletal muscle, the muscle that use to move around, and nerves, transmit electrical signals, are specifically designed to be highly sensitive to electrical signals. That's why your brain thinks to move your finger, and you send a tiny signal down, you can do it. And that signal is the factors, the features that make the cells very sensitive to tiny electrical signals also make them very vulnerable when they get a non-physiologic, high, strong signal, such as an electrical shock. And that damage, as we talked about, this non-thermal type of damage, happens on the scale of microseconds to milliseconds as opposed to seconds. So when we think about safety and design principles, that's another frontier that we need to think about going forward. And here we see a modeling, the combination, the computational modeling was just beginning, and we need to do a lot more of that, perhaps in collaboration with you guys to really kind of educate ourselves about what to expect, so that can be used, in the medical community to educate and train new physicians coming in about what to anticipate in terms of areas of damage and electrical shock. So in 1991, as Lanny Floyd mentioned, in collaboration with Mary Capelli and Neil Pliskin and several other people, we formed a multidisciplinary organization to try and understand what was going on with these patients that were often referred to us, who had all kinds of problems that we didn't think should be related to electrical shock, especially when the electrical shock might have gone from hand to foot, and now they have psychological issues. How'd that happen? No one believed that, okay, because there was no brain current at all. So anyway, you'll hear a lot more about that. And so that team has grown. I think we've made some contributions in understanding that, and you're going to hear from the World Authority about that in a minute. And now there are programs like that one in other countries like Canada and France and China, which is shown here. We have actually active collaborations trying to understand and make progress to improve the outcomes of patients with electrical shock injuries. So just to lead into Dr. Pliskin, I've already said that nerves and muscles are designed to are to be very sensitive and react to small electrical signals. And when you get a shock, that and the nerves are not designed for that, and the muscles are not designed for that, they become damaged, and of course, the peripheral nervous system and the central nervous system are all one system. They're all connected together. When you damage the peripheral nerves, there are immediate adaptive changes in the spinal cord. And then when that nerve heals, it changes back. And I can't convince it to change. Did I do something? Well, I'm the guy that's pushing it too fast now. Trying to make up for time. Okay. Sorry about that. Oops. All right, so when the peripheral nervous system is injured, and then it usually takes some time for the injury process to start to repair itself through peripheral nerve regeneration. And then when the nerves regenerate, particularly we're talking about the most sensitive nerves are the ones that control muscles, and which is the top priority for the spinal cord to keep your posture and balance and coordination. And when they heal back, they don't exactly heal back to the same place most of the time. And not just for electrical injury, but for all kinds of injury. And that's been well demonstrated by neurophysiologists for decades. So you can imagine getting injured with an electrical shock. The nerves heal back, but now the circuitry, the peripheral circuitry feeding back information to the spinal cord is giving it different information than it got for the first X number of years of the person's life. And then that leads to coordination and balance problems, which then leads to muscles not coordinated properly within itself and causing trigger points and chronic pain. And then chronic pain, let me just show you this one video of a lady who was working in the kitchen, and one of the carts, electrical heating carts, had a grounding problem. She had a 240 volt shock, no physical burns. Her hands were wet. You could talk, and here she is 9 months later, can walk fine with her eyes open. I tell her to walk in a straight line, not toe to toe, but walk just in a straight line with her eyes closed, and you can see what happens. So that's a very common manifestation. And imagine trying to do a job like climb up on a ladder and wire something and hold a few other things that you screw in something at the same time. You can't do it as fast. So that coordination problem leads to trigger points, and then that chronic pain from those kinds of things, we think. And what I'm telling you now is all what we would call hypothesis that we're trying to test and understand to learn better how to intervene if it's true. But that's what that's where the focus of our research is right now, and that leads to lots of central neurological problems. And Dr. Pliskin is going to take it from here, and he is indeed the world's expert on and a consultant to every organization you can think of on electrical injury. Dr. Pliskin.
Thank you very much, Dr. Lee. And I apologize for not being there in person. I really wish I was. The weather sounds like it's a lot better than in Chicago. So I'm going to use my time to talk a little bit about electrical injury and what we've learned. And it occurs to me that maybe some people in the audience don't understand what a neuropsychologist is. I'm a clinical psychologist with specialty training in the neurosciences. And this is not rocket science. I mean, these are performance-based tests. You come into a room, it's quiet, you sit down, and somebody asks you to learn and remember information or do other tasks. And then we compare how you do to other people your age. So things that I'm going to show you about cognitive status and emotional status, it's not just based on impression. It's not based on impression at all. It's quantitative information. So I'm very delighted to share with you some of the information that we've gathered, and that's the royal we. We actually have data that goes back pre-2000, but we haven't really gotten through it yet. But I want to show you that since 2000, the CETRI program and myself have seen 185 people who have had electrical shock injuries. Now, I'm just going to say this one time because it's important information, and I'll say it up front. The people who came to the CETRI program are people who are having difficulties. So everything that I'm going to talk about are related to people who sought treatment. In our field, we call it a convenience sample. That doesn't necessarily mean that that's what the experience is for all people who have had electrical injuries. And in fact, I'm quite sure it's not. So understand that what I'm going to present to you is our group of patients who came to see us because they were having problems as a consequence of their electrical injury. And this sample of 185, I tell my colleagues and my students, it's like gold, because most clinicians, at least in the US, they don't have much experience with electrical injury. They've seen a few, especially in my field, they've seen a few. So out of these 185, they fit the demographic that you already know. They're mostly male. Right-handed is a neuropsychology thing. They're a young group, age 43, even though there's quite the range. And also, they are, as a group, high school educated. The range should be from grade 8 to grade 20. The sample demographics are 84% white, 8% Black, 7% Hispanic. And the type of injury contained in the sample that I'm going to show you, there's 10 lightning strikes in there, but they're excluded from all the studies that we've done. I'm going to show you because lightning strike is obviously a very different kind of, I'm telling this to a group of engineers. So, so the things to tell you about our sample is that 80% of them sustain their injury through contacts, continuous contact, and 20% through arcing. Out of our sample, less than half had contact burns. 7% fell off a ladder or were blown backwards and also sustained a traumatic brain injury. Less than half had a loss of consciousness, which is relevant, and I'll explain why in a moment. 62% hospitalized, 31% requiring surgery, and I say only, thankfully, 5.5% who suffered cardiac arrest. Now, these are key demographic issues when you do the work that I do as a neuropsychologist, because everything that I showed you is voluntary. We bring you into a room, we ask you to do stuff, and we assume you're going to try hard. And sometimes people in compensation, anybody who works with electrically injured patients understands that there's workers, since it's a younger sample, it's workers' comp, there's civil litigation, there's personal injury. So 79% of the sample is engaged in one form of litigation or another. It's just a fact of this kind of work. And then the other points are that, and I'll get back to this later, that 3 out of every 4 people had no prior psychiatric history. And 38% had, let me say that again, 25% of our sample had no prior psychiatric history, and 38% of our sample did have a history of migraines and other neurological issues. So with that high rate of litigation, the field of neuropsychology has changed a great deal. I know this is a busy slide, but here's the main point. Neuropsychologists now give tests that are designed to look like memory tests or speed tests, but even people with significant brain damage can do them easily. So they're designed to trip up people who are purposely attempting to game the system. And so applying modern standards of making sure that everybody who you include in the sample actually tried hard and gave you valid data, we now give what are called performance validity tests. And what we are discovering is that 21% of the people that came in to see us failed their performance validity tests, meaning that we could not interpret their test data. Also, an invisible injury doesn't mean no injury. I don't know why I put that there. It was a random thought that I had. But I think that what happens is that sometimes people come in, they look fine, they sound fine, they talk fine, everybody expects that they're fine, and then they're not. And the automatic assumption that people make, especially in my field, is they're not being genuine. Well, 21% of our sample, that turned out to be the case. So since I'm on limited time, I want to just summarize what we've learned after 2 decades of working with these patients. The first thing I want to tell you is that electrically injured patients experience cognitive dysfunction. But this cognitive dysfunction is very different than what you see in traumatic brain injury. In traumatic brain injury, somebody, let's say, you're in a car accident. Here's where the car accident occurs, right at this point here. So you have a loss of consciousness, and then you have a period of time that you're confused, and then you start to wake up again. This period of time between loss of consciousness and confused, the person will never remember that time. It's called post-traumatic amnesia. So the way that you measure the severity of a traumatic brain injury, like somebody in a car accident, is did they lose consciousness, and for how long? Did they have this post-traumatic memory loss? And the other thing that's key is that the most evidence of damage of injury occurs closest to the time of injury. Now, when you contrast that to what we've learned from our 185 electrically injured patients, is that electrical injury severity cannot be considered as a traditional traumatic brain injury. And the reason that I'm harping on this is because the workers who are injured, who do they go and see? They go and see their primary care doc. They go and see their neurologist. And if they don't have any experience with electrical injury, then everything gets filtered through the lens of traumatic brain injury. So in traumatic brain injury, you expect loss of consciousness. In electrical injury, it happens less than half the time. In traumatic brain injury, you expect that gap in memory after the event. It occurs 30% of the time in electrical injury. I said that when somebody has a traumatic brain injury, like a bad concussion, the most acute effects are seen right after the injury. The conundrum with electrical injury is that sometimes the effects are delayed and they're not apparent right away. Finally, in traumatic brain injury, you give them an MRI, you see an evidence of a bleed or a bruise, and you make certain assumptions. They've had a traumatic brain injury. What our experience has taught us is that when you do MRIs, traditional high resolution 3 Tesla magnet MRIs, with these folks, most of them do not have evidence of structural brain damage. So if nothing else, I've spent a lot of my time, and I'm a clinician and an educator, trying to educate my colleagues just about this one distinction between traumatic brain injury and electrical injury, because what ends up happening is these folks end up with electrical injury, end up not getting the treatment that they need. And if they don't get the treatment that they need, then guess what happens? There's delayed effects. So, okay. And there are delayed effects. And we followed over time our convenience sample, and we see that yes, there's symptom complaints early on, and there's symptom complaints that persist over time. What are those symptom complaints? This is why Dr. Lee reached out to me in the first place, because half the sample was saying that they were having memory problems and word finding and concentration problems. And by the way, this is compared to my wonderful International Brotherhood of Electrical Workers, Joliet branch, who served as healthy electrician controls for some of these samples. And here's what I hear from my patients. It's not that I can't do things, it just takes me longer. My brain feels like it's on screen server. I hear this one a lot. What was automatic is no longer automatic. I'm slow. I can't track things as easily. These are the kinds of things that I hear. So what are the objective findings show when we give them these? So we only include people who pass their performance and symptom validity testing. We match them for level of intelligence. We make sure that they have no traumatic brain injury in their background. And what we find is that as a group, they're slower. They don't have amnesia. They don't have dementia. They don't have language disturbance. They're slower. They're less able to pay attention. And so that's a key point. Neurocognitive changes occur after electrical shock injuries in our convenience sample. They're generalized impairments. They're not specific impairments. So we don't typically expect to see someone who comes in who has an amnesia or a focal neurological deficit. And what we've learned in 2+ decades is that there are multiple contributing factors to this, which I'm going to go through now with you. But here's the take-home message, that the origin of cognitive impairment and electrical injury is multifactorial. And you have to recognize what these different factors are. And by recognizing them, you can design optimal treatment strategies to pursue proper diagnosis and treatment. Too many times, I've seen electrically injured individuals not taken seriously or seen as weak in character. But here's also what I've seen. I've seen a lot of these individuals who experience comorbid pain conditions, disrupted sleep, trauma and problems with emotion regulation. They're taking a lot of medications. Suddenly, the thing that they've trained their whole life to do, now suddenly they have unrealistic and unusual fears that prevent them from and cut them off from what they do. And then the big unresolved question is, what's the direct effect of electrical exposure on the central nervous system, if any? And just so you know that this isn't a Chicago thing, here's an article that just came out from the French group within the last month or two, following electrically injured patients over time. Their sample was 76 adults who they followed after a year. And the problems that they grouped were neurologic and psychologic problems, and pain mixed in here too. So we've done our own studies with looking at electrical injury and chronic pain. And what we have found is that the impact of chronic pain affects both mood and thinking abilities after electrical injury. This study is in press right now in the Journal of the International Neuropsychological Society. And after you adjust for their medication use, higher pain levels are associated with, surprise, a harder time paying attention. And if you have a harder time paying attention, you're going to have a harder time remembering. Depression is significantly correlated. It's a complex brew. And when you compare electrically injured and chronic pain patients from other sources, they don't look any different. So we have, like, in this study that I'm talking about, we took folks who had like low back pain and were candidates for surgical intervention for their low back pain. And we tested them, and cognitively, they didn't look any different than our electrically injured patients do. So we know that pain is absolutely a component. Here's this French study, and now they looked at the percentage of patients, and at the top of their list of initial symptoms is pain as well. And mixed in here along the way, we've got anxiety and tiredness, we've got confusion, amnesia, I'm not a big supporter of, and then some of these quasi-neurologic symptoms of malaise and hearing loss. And so the key point is that electrically injured patients' pain experience influences their memory, their concentration, and their emotional functioning. And that injury characteristics, the chronic pain, the life complications, and then the changes in emotions that occur are the origin of this cognitive impairment. So you need a team of people. You need a cardiologist, you need burn specialists, you need health psychologists, and maybe even a neuropsychologist. Here's the second thing that we know from working with these patients for so many years, and I know I only have about 8 minutes left, so I'll be quick. Electrical injury patients develop changes in their mood and emotion. I've already told you that 25% of our sample had a prior history of psychiatric contact. That means 75% did not. And what we're finding is that post-traumatic stress disorder, stress, anxiety, all of these are part of the electrical injury experience. And the more diagnoses you have over time, the more cognitive impairment that you show. Let me say that again in English. If early on you are experiencing changes in emotional functioning as a consequence of electrical injury, and you have more than one diagnosis, like anxiety and post-traumatic stress or anxiety and depression, and you follow them cognitively over time, those folks who have the psychiatric complications are the ones who also have the most cognitive impairment. So we have a high frequency of depression, post-traumatic stress, and anxiety in this population. And again, our board certified psychiatrists tell us that 78% of our convenience sample had a treatable psychiatric disorder versus the 25% with prior history. And the prevalence of this morbidity increases over time if you do not address it. So here's a study where we looked at patients who we tested twice. And over a period of time, those folks diagnosed with psychiatric conditions, just plain and simple, did worse. So electrically injured patients experience psychiatric changes and particularly problems with emotion regulation. These symptoms aren't a character flaw. They're not the sign of a weak personality. They're symptoms of emotional trauma and possibly the effect of the electrical exposure on central nervous system function. And the third point is that it remains a major source of disability for patients that affects patients years later. And we've done a bunch of studies looking at testing patients over time and finding again that worsening depression symptoms are associated with worsening mental speed. So for at least a subset of electrically injured patients, those who develop psychiatric symptoms during the post-acute phase, it has a detrimental effect on their functioning. And listen, the reality is that there's still a stigma associated with mental health and behavioral health issues. And some people suffer in silence. And they don't get better when they suffer in silence. They need help. It's a chronic concern that can impact long-term adjustment. This is from the recent study looking at from the French group, and it looks at like what are the different complications over the years, and you can see that in the folks they studied, and this is for them, they followed up with phone calls essentially. But psychiatric and psychological and neurological complications remain part of the clinical picture. So in conclusion, electrical injury is a cause of significant disability. When cognitive impairment emerges, it's not usually due to just one thing. And you can't consider these patients as traditional traumatic brain injury patients. That's what I tell my colleagues. That's what I tell physicians when I talk to them. But electrical injury can lead to significant changes in behavior and chronicity. And that's why early identification and targeted treatment is so important. So what we've learned is over time is that neurocognitive impairment is not typically the primary problem in these folks. Treat their pain, treat their sleep, address their medications, make sure that their psychiatric status is addressed. And then you'll be in a position to minimize the neurocognitive impairments that they do have. Early attention to mood state is critical because these problems can persist for years, and people can be socialized to the idea of, I'm sick, I can't work. So early intervention really, really matters here. That's the message. And recognition and treatment of chronic pain conditions while limiting the long-term dependence on opioids, and recognizing and introducing physical rehabilitation into the mix. What we don't know, this is my last slide. Here's what we don't know. We don't know exactly what effect electrical exposure has, either directly or indirectly, on central nervous system function. Dr. Lee and I have many discussions about this. What we don't know is that why these mood and emotion regulation problems develop. And you can say, well, the person was in a near-death experience, but I've had firefighters, I've had emergency medical responders, like the most stress-resistant people that you can imagine, who still experience major disability and changes associated with changes in their emotions. And I'm not clear how much of that is in reaction to a situation that they've been in versus how much of that is an effect of the electrical injury itself. And that's why I conclude by saying that the lack of clarity in brain contributions inhibits the development of more effective post-injury interventions. We need more functional imaging studies. We need different ways of looking at the brain. And I'll stop here and turn it back over to Dr. Lee.
At this point, I think we're happy to take any questions.
I'm sorry.
Thank you. Thank you, Neil.
All right, you want to take questions? Okay.
Yes.
Any questions? Over here.
Yeah, Bob Herzig, Herzig Engineering. Extremely fascinating and very enlightening to see the real life and empirical part of the presentation from, actual test data. So as an employer of electricians, my concern is what pathway forward do we need to consider hiring people that have been through serious electrical shock conditions like you've outlined? And also, I'd like to ask, where could we go to follow you more closely, real time, on the research and the fascinating data that you guys have presented?
So I'm going to say a couple of things. And Neil, did you hear that?
I sure did.
Okay. All right. So my two comments are this. The first thing really is, and as a major problem, is that up until recently, the third-party payers, which were listening to mostly trauma surgeons and so forth, didn't believe that any of this was tied to electrical injury, anything that, so they did, and the reason why so many people really had to get an attorney to get any kind of medical care is because they were just simply cut off, and then get early care, no aggressive early intervention and so forth, because now there are a number of studies that, and people, it's no longer ignorable. So that's number one in terms of what needs to be done going forward about that. And so getting, helping individuals get early intervention in terms of experience rehabilitation is really, I think, an important thing. The second thing, part in terms of how do you manage someone or how, who had an electrical injury and what needs to be done, I'm going to ask Dr. Pliskin. I'll defer to Dr. Pliskin on that question.
Well, okay, so I always break it down into three categories. Their physical symptoms, their cognitive symptoms, and their emotional status. Now, the way I understood your question was, how safe are you at hiring people who have had electrical injury? Am I understanding that question correctly? Or what to do about it when you have an employee that has an electrical injury?
Yeah, of course, we're in a dangerous industry where people are expected to be around energized conductors at times, and so, to hear that their cognitive, their motor skills are slow and delayed is concerning because it, puts them again in harm's way.
Absolutely. And so, without doing too much damage to the industry, I would say that if you know that someone's been through that kind of experience, it's not unreasonable for them to have a cognitive evaluation done, a neuropsychological evaluation done. And that can be accomplished really through the primary care physician can arrange that. But I mean, what you're asking for are performance-based measurements of someone's capabilities. And if you know that someone's been in a significant injury and you have concerns, get them evaluated.
And I would add to that we often, when we see those patients, they really get a comprehensive evaluation, not only psychological evaluations, but oftentimes psychiatry. We have a physiatrist and a neurologist who's now seen over a couple hundred of these patients, and depending upon what they need. So it really takes a team effort, and the team meets and puts together a comprehensive report. And I do think it takes, because of the complexity of this type of injury, a team evaluation is really critically important.
All right, over here, please state your name and your organization.
Okay, Lanny Floyd, University of Alabama, Birmingham. Again, thank you both for being here. We're coming at the group here in this audience, for most of us anyway, we are concerned about how to change the culture of the acceptance of electric shock with no apparent injury. So we're not coming at it from the from the side that you are coming from and how to evaluate the neurological impact. But how do we change the culture where people understand that just because you walk away from the injury, that it was okay? And I don't know, not asking that you have the answer on that, but we're launching a study group or a ad hoc committee. We actually launched that this week, where we're going to be trying to bring some ideas together on how to better influence the culture of acceptance of electrical injury with no visible, apparent, immediate injury. And I don't know if, hopefully we'll have ways to collaborate on that. You may have ideas on that. Again, I don't think we have the answer right now, but I'm curious about your thoughts on that.
I've got an answer. Education, absolutely critical. And it's really no different than what I face in terms of the stigma every day from people who have behavioral health and mental health issues. They're all invisible unless you ask about them. And that's how you find out. So how do you change a culture of acceptance is by talking about it and educating people. So that means bringing in people who have had electrical injury experiences, legitimate ones, and have them talk about their experience, and for funding for additional research to try to get a more granular understanding of what influences the behavior changes in these individuals. But sometimes the folks with the invisible injuries, they do worse than the folks who've had amputations or more obvious burns. Does that answer your question?
Well, it really is a help. It gives us a jump start on some things we can think about doing. Thank you so much.
The other thing, Lanny, just to say, I know we're almost out of time, but there's a certain amount of inertia of change, in the medical community. Now, Neil Pliskin was the very first person to report these kinds of issues, in a large enough scale. But Joel Fish from Canada, now we have the group from Paris. We got several others and several others from the United States as well around the world. So now it's gotten to the point that the evidence is irrefutable. It's just not one person's perspective on it. And I think, it's time to really, and the docs in the medical centers are beginning to change too. I think that's been a bit of a problem, but it's just sometimes takes longer than we ever hope for these kinds of changes to take place.
Yeah, thank you very much.
Mike O'Brien with Exponential Power. Since a lot of people are very reluctant to report shocks, especially on the job, and some of these injuries are not, they don't manifest themselves the same in each person, is there any benefit to, say, like a pre-employment baseline testing? And if I think there'd be a benefit, but is there such a thing? Thinking along the lines of hearing conservation programs.
Oh my God, I love you and I've never met you. I mean, what an absolutely fabulous suggestion. And all it took was millions of dollars of lawsuits for the NFL to figure out that they needed to do baseline testing before they started their season with their football players. So your suggestion is spot on.
Thank you. We'll take these.
And by the way, these pre-screening evaluations are quick.
Tom Zampel, Electric Power Systems, thank you. Do you have what the electrical injuries were that caused them to, look for you have a list of those. The idea is to try to understand at what point does an electrical injury become serious? At what voltage, current, burns, whatever?
Yeah, we're just simply not at that point. Hopefully we get there. We're trying to figure out, in that convenience sample that Dr. Pliskin referred to, what really can we, what are the mechanisms? Because, the electric field strength, in terms of the physics is strong enough, in the peripheral extremities, not strong enough when it gets to the spinal cord. Very few people have direct shocks to the brain. And so we're trying to put together, that's our main research effort right now, to understand that. And once we do, then I think we can address thresholds. But yeah, I agree with you. That's what needs to happen.
Of what you have observed so far? I mean, as far as, what occurred to cause those electrical injuries that you could share? Maybe you can at this point.
I'm sorry, I don't understand.
In other words, every person you interviewed had an electrical injury, and it was caused
Yes.
by something. And
The answer to the question is yes. We in our database that we've done by grassroots, we have specific information about the nature of the contact. Was it hand to hand? Was there evidence of thermal injury? Yeah, we have all of that information on that 185 people.
And
we're
then
just starting to go through it.
that's affected by body position, what kind of clothing, what they were standing on. The whole circuit matters. It's not simple.
Okay, thank you.
All right, last question, please.
Zach Thompson, Interjection Renewables. I was just wondering how many of the patients that you saw had prior diagnosis of like ADHD, and if there was a significant or discernible difference in their emotional state and stuff like that after the electrical shock.
I can't give you an exact answer of how many people had ADHD. The overall sample had 25% had some kind of condition, and I would have to go back and look and see if ADHD was that condition. What was the second part of your question?
Sorry, sat down. If there was a discernible difference in the emotional state afterwards, I guess it would also depend on whether they were untreated or treated.
Yeah, when you think about ADHD, you think about impulsivity, you think about hyperactivity, you think about inattentiveness. What we've seen more in our sample has been high anxiety, fearfulness, depression, avoidance of all things electricity related. And if you superimposed all that on top of someone with ADHD, of course, it would make them even more dysfunctional. But even just having those symptoms without ADHD is what has led to the findings of attention and processing slowness. And I just wanted to say one more thing. Somebody had asked earlier about how to keep track of our work, and that would be through CETRI, CETRI.org. That would be the place where we would post our new publications. And of course, I'm available to talk at any time. My email is npliskin@uic.edu.
Excellent. Well, thank you, Dr. Lee and Dr. Pliskin. Thank you very much. Great presentation. I really appreciate all that you do. Thank you. Excellent.